ಪಾಠ ಪಠಣ ಗುರು ಬುದ್ಧಿ ವಚನ ಇದು ವಿದ್ಯಾದಾನ ತಾಣ. ಪಡೆದಾಗಲೇನೆ ಸಿರಿ ಶಿಕ್ಷಣ ನಮ್ಮ ಅಂಧಕಾರ ದಮನ. ಮಂಗಳೂರು ವಿಶ್ವವಿದ್ಯಾನಿಲಯ, ಮಂಗಳೂರು ವಿಶ್ವವಿದ್ಯಾನಿಲಯ, ನಮನ ನಮನ.
ಜ್ಞಾನವೇ ಬೆಳಕು, ಬೆಳಗೋಕೆ ಬದುಕು.
ದಿನ ಪಾಠ ಪಠಣ ಗುರು ಬುದ್ಧಿ ವಚನ ಇದು ವಿದ್ಯಾದಾನ ತಾಣ. ಪಡೆದಾಗಲೇನೆ ಸಿರಿ ಶಿಕ್ಷಣ ನಮ್ಮ ಅಂಧಕಾರ ದಮನ.
ಮಂಗಳೂರು ವಿಶ್ವವಿದ್ಯಾನಿಲಯ, ಮಂಗಳೂರು ವಿಶ್ವವಿದ್ಯಾನಿಲಯ, ನಮನ ನಮನ. ಜ್ಞಾನವೇ ಬೆಳಕು, ಬೆಳಗೋಕೆ ಬದುಕು. ಜ್ಞಾನವೇ ಬೆಳಕು, ಬೆಳಗೋಕೆ ಬದುಕು.
Good evening to all. I am Kishore Kumar CK, Director of Physical Education, Bangalore University. I am privileged to welcome you all on behalf of Department of Physical Education, Bangalore University, to the international webinar on physical activities for elderly people and other chronic diseases. In this webinar, we are focusing on lifestyle and in particular physical activity as a driver for a healthy and long life for elderly people. A recent study found that physical activity was the number one contributor to longevity, adding extra years to life. Even if you don't start exercising until your senior years, but getting active is not just about adding years to your life. It is about adding life to your years. Getting moving can help boost your energy, maintain your independence, protect your heart, and manage symptoms of illness or pain, as well as your weight. Regular exercise is also good for your mind, mood, and memory. It's never too late to find a simple, enjoyable ways to become more active, improve your mood and outlook, and reap all of the physical and mental health benefits of exercise. No matter your age or physical condition, it's never too late to start exercising and get fit. Today's resource persons, Dr. Kilmer and Dr. Sonia Raval from Department of Physical Therapy, University of St. Mary, Kansas, USA, will give you easy tips, will help you get started, safety, and make it fun. This webinar will surely benefit the elderly people and to others to improve their knowledge in this area. This great idea was given by Professor Anand Shetty, head of the department, St. Mary's University, Kansas, USA. In our last international webinar, Dr. Anand Shetty had presented so beautiful on energy systems consideration for training. More than 14,000 people had participated in that webinar. Sir, I am really grateful to you. May I now request Mr. Ramesh H.N., Assistant Director of Physical Education, Joint Organizing Secretary, former hockey player and qualified hockey coach, to welcome the guests and participants to this international webinar. Over to Mr. Ramesh H.N.
Very good evening, all of you. Department of Physical Education, Mangalore University welcomes you to the international webinar on physical activities of elderly people and other chronic diseases. Today, we have with us Honorable Vice Chancellor of Mangalore University, Professor P. Subramania Edapaditaya. It's my privilege to welcome the respectful Vice Chancellor of our university, an internationally renowned scholar in the field of commerce and management, who has great interest towards the development of sports in our university. He is instrumental in providing good facilities and scholarship to our university sports persons. He is also the brain and strength behind in implementing new sports programs in our university. On behalf of the Department of Physical Education, I extend a hearty welcome to you, sir. Today we have eminent scholar Dr. Phil J. Kilmer, instructor of physical therapy, University of St. Mary, Kansas, USA. On behalf of Department of Physical Education, Mangalore University, I extend a hearty welcome to you, sir. We have another eminent scholar, Dr. Sonia Raval, Assistant Professor of Physical Therapy, University of St. Mary, Kansas, USA. On behalf of Department of the Physical Education, Mangalore University, I extend a hearty welcome to you, ma'am. I welcome our dynamic registrar, Sri Raju Mogavira, KS, members of the syndicate, Professor P.L. Dharma, Registrar Evaluation, Professor P. Narayan, Finance Officer of Mangalore University. I also welcome Dr. Kishore Kumar C.K., Director of Physical Education, my colleagues in the department and esteemed participants of this webinar. Welcome you all once again. Thank you. Over to Director of Physical Education.
Thank you, Mr. Ramesh. May I request Mr. Pratap P., Physical Education Director, former national wrestler and judo player, and he has represented Bangalore University several times in wrestling and judo. Now I request him to introduce today's speaker, Dr. Phil Kilmer, to our esteemed delegates. Over to Mr. Pratap P.
Good evening to everyone. It's my immense pleasure to introduce our today's resource person, Dr. Phil J. Kilmer. Dr. Phil J. Kilmer earned a Bachelor of Science in Biology, pre-medical with a minor in chemistry from Emporia State University. He went on to complete his doctorate in physical therapy from the University of Kansas Medical Center, where he was the liaison and coordinator for the JDoc PT Pro Bono Clinic. Following graduation, Dr. Kilmer served Kansas City Public Schools in Missouri for 1 year as a pediatric physical therapist. He then transitioned to working with the geriatric population in a skilled rehabilitation setting and soon began a partnership with the KUMC department program as a clinical instructor. Dr. Kilmer served on KUMC's Commission on Accreditation in Physical Therapy Education Review Panel as an experienced clinical instructor, as well as on KUMC's admission board. Dr. Kilmer began working as an adjunct professor for the Stephanie Doctor of Physical Therapy program in 2018 and has since joined as a full-time instructor. Dr. Kilmer currently serves on the Kansas Physical Therapy Association Board of Directors as the Public Relations Chair and is also a member of the KPTA Reimbursement Committee. Thank you, sir.
Thank you, Mr. Pratap. Friends, we have reached the much awaited moment to hear to the distinguished personality, Dr. Phil Kilmer. May I now request Dr. Phil Kilmer, an eminent physical therapist of international repute, to deliver the lecture on physical activity for elderly people. Over to you, sir.
Welcome. Today's presentation will be Health and Wellness of the Older Adult, from Frailty to Fitness. A little bit about myself. My name is Phil J. Kilmer of the University of St. Mary. I received my Doctor of Physical Therapy from the University of Kansas Medical Center in 2010. I then started practicing as a physical therapist for the last 10 years, mostly in the geriatric population. Again, I'm currently an instructor in the University of St. Mary's Stephanie Doctor of Physical Therapy program. I am also involved in the physical therapy field on both the state and national levels. I serve my state chapter of the American Physical Therapy Association as the Public Relations Chair, and I'm also currently the Geriatric State Representative for Kansas. A few other fun facts about me. I'm a father and pretty massive Liverpool fan. So for those Liverpool FC supporters there, I am the vice president of the official Liverpool FC Supporters Club in Kansas City. I've had the great pleasure to travel all over the United States and over to England to see Liverpool numerous times, meet numerous players, and of course, Coach Klopp there. So it's a big fun part of my life and things I like to do with my boys. And one last thing, I don't just have a passion for talking about exercise and nutrition, but it's a major part of my life. I've been practicing natural bodybuilding for the last 5 years or so, more seriously, and this last year received my pro card in the IPE, Natural Bodybuilding Association. So as for the objectives today, by the end of this presentation, I'd like you to understand what aging successfully is. I want you to be able to understand the different components of frailty, as I believe the background and kind of components of frailty are a good way to look at what we need to address to overcome frailty and to be able to lead our patients to age successfully. I want you to be able to understand some of the screening tools and objective measures that we use to identify at-risk populations for frailty. I want you to understand the general activity and nutritional recommendations for the older adult. And finally, I want you to understand tools to increase compliance with exercise and nutritional interventions so that we can actually help our patients and individuals make those actual changes that are going to change their life. So first, let's define successful aging. The definition of successful aging includes 3 key behaviors or characteristics that should be perpetuated as long as possible. So these include a low risk of disease and disease-related disabilities, high mental and physical functioning, and finally, active engagement with life. especially that third one, that active engagement with life. That really helps our patient develop that subjective well-being, which we're going to talk about. So not only the biomedical aspects of activity and nutrition to minimize that risk of disease and disability and maintain that high function, but also being able to use that function to engage with life and in activities that actually make their life very rewarding, or what we call optimally subjective well-being. Okay? So first, I think it would be productive to just define frailty. So frailty is a clinically recognizable state of increased vulnerability resulting from aging-associated decline in reserve and function across multiple physiologic systems, such that the ability to cope with everyday or acute stressors is compromised. So as you can see in this diagram, which I think is helpful, on the far left, on the y-axis, we have functional capacity rated from 0% to 100%. And then we have on the x-axis chronological aging from arbitrary 0 to advanced age. You can see on when a patient is very young on the chronicle aging on the x-axis, their functional reserve is very high. So when you're youthful, you have a lot of things working in your favor, meaning that you can have slight things happen to you, but you still have a large reserve of functional reserve. So you may get sick, but a child who gets sick doesn't get into the point where they're frail and unable to walk or unable to care for themselves. So as you see with normal aging process, we are going to see slight declines just from physiological changes that do happen over time. Now we are going to talk about different ways we can attenuate those changes. However, we do expect a normal decline over time. But what you can see with accelerated aging is that we're going to have that loss of independence going from independent to frail much closer in the chronological age bracket. So we see patients who are falling into that frail category much more quickly, and then again into the disabled category much more quickly and earlier in their lifespan than they would someone who's aging normally. So we're going to talk about some of the things, some of the definitions of the cycle of frailty, and kind of the operational definitions of frailty, ways we can test for frailty, and then finally how we combat some of these comprised energetics and actually keep our patients from becoming frail in an overall kind of picture of wellness. So this is a diagram that we are going to revisit throughout this talk. This is a great diagram of kind of the cycle of frailty, because all of these things are very interrelated, and I really want that to be a major takeaway that you take from this presentation, is that all these different aspects that we're going to talk about, weight loss, decreased activity, decreased walking speed, strength, sarcopenia, which we'll define and talk about, undernutrition, falls, all these things happen because they're all interrelated. And when we have kind of one domino fall, we tend to have several dominoes fall as well. So we're going to talk about the different aspects of this and then how we can actually attenuate this process. So in the absence of a kind of a gold standard, frailty has largely been defined as meeting 3 of the following criterion, which are largely just talking about comprised energetics. So what we see is the 5 different criterion are low grip strength, low energy, slowed walking speed, low physical activity, and unintentional weight loss. And again, to be functionally defined as frail, you have to meet at least 3 of those. But we're going to talk about how they're so interwoven together, as you can see in the diagram. Oftentimes, when a patient meets one, it's going to cause you to meet several others. That's why they are really a good proxy for how a patient is actually doing. So again, back to the energetics, Schrack et al. Really proposed that maybe frailty is just really deteriorating function is just all about energy. So with increasing age, energy availability overall declines, and then energy needs actually can increase because a patient has become weaker. And we're going to talk about kind of that role of sarcopenia, loss of muscle, lean muscle mass, poor, inadequate nutrition, how that all kind of plays into this. So these patients have less energy reserve available to go beyond kind of that whatever is necessary just for maintaining homeostatic equilibrium, because they're not taking in enough energy and because they're becoming deconditioned by not actually moving or being physically active. On top of that, losing muscle mass. So this really supports the notion that slowed gait speed and decline in physical activity might actually be adaptive responses to conserve energy expenditure. So again, in that kind of cycle, the body's just trying to maintain homeostasis. So at some point, if a person is not taking in adequate nutrition, their body is telling them to slow down, not to waste energy, because you don't want to waste away. So your body is kind of down-regulating your energy expenditure. Well, then that down-regulation in energy expenditure means the patient isn't moving as much, which means they become more deconditioned. And again, that cycle kind of continues. That is why slowed gait is a big predictor of frailty and mortality. So next we're going to go through those 5 different aspects of frailty and talk about them a little bit more independently. So the first one is low grip strength. So that reduced muscle strength as measured with grip as a proxy for overall muscle strength has been highly associated with increased risk of all-cause mortality as well as cardiovascular mortality. That's why grip strength is such a quick, simple, and inexpensive means to actually determine a person's risk for cardiovascular death and overall mortality. Also, weak hand grip later in life is also a risk factor for disability. You think about all the different things a patient has to do with a strong grip strength as far as carrying items, practicing different ADLs, cooking for themselves, lifting things. That's why it's such a big carryover. It's also an independent risk factor for morbidity, mortality, and it really is central to the definitions of sarcopenia and frailty, like we're going to discuss. So that's the first aspect. The second one we talked about on that diagram was fatigue. Fatigue is really one of the most common reasons given by community-dwelling older people for activity restriction, and it is frequently reported as the cause of disability. So again, when we talk about fatigue, those people are deconditioned. They're not going out as much. And when they're not going out as much, they become more deconditioned and more fatigued. Again, we talk about all those energetic issues. So they're not taking in enough nutrition. All this kind of feeds into these same pathways. So prevalence study suggests the rate of self-reported fatigue among older people is quite high. So 25% of all older individuals in primary care and up to 98% in long-term care are reporting significant fatigue. So how it was originally determined by Fred et al., who was the one who labeled those 5 criterion, they actually measured for fatigue just by asking a few questions. These questions were pulled from the Center for Epidemiological Studies depression scale. So there are actually 2 questions about fatigue pulled from a depression scale. So the participants were each asked how often in the last week they felt that everything they did was an effort. And the second question was how often in the last week could they just not get going? So they tested positive for fatigue if they answered either moderate or most of the time during the past week for either or both of those above questions. Again, these are very easy questions to ask, and easy questions that you can work into a subjective examination as a physical therapist in order to really determine if a patient is experiencing fatigue. So these are two good questions that we can definitely pull away and put into use. One of the biggest things I think we should take away from this is slowed walking speed, kind of the third indicator. So walking speed is really a massive indicator of mobility in general, which makes sense. High specificity of walking as most people's means of actual mobility. This is a great diagram on the right on what walking speeds are actually needed or how they match up to different functional levels. So we're really going to talk about 0.8 meters per second is usually the cutoff for a couple different things. So that's the cutoff for frailty as defined by the 4-meter walk test. We're going to discuss the walk test on the next slide here. It's also a component for diagnosing someone with sarcopenia, which sarcopenia is something we'll address a little bit later as well. So really remembering 0.8 meters per second is a pretty good cutoff, meaning those patients are starting to really not be very successful with walking or mobility. As you can see, you really need to be at least 1 meter per second for kind of being independent with ADLs. So that's another pretty good cutoff that a lot of our goals we should be writing for our patients should really be based around about 1 meter per second walking speed, while normal walking speed is all the way up to 1.2 to 1.3. Okay, again, as you see on the very bottom of that diagram, 0.8 is the cutoff for a community ambulator. Again, so one of the big takeaways I like people to know is when you are doing walking speed, really that 0.8 and 1.0 are two big numbers to remember. When you're dipping below that, we're really getting into patients who aren't being very successful with mobility or walking. Again, when you get down to 0.6, the rate or risk for hospitalization is very high. The fall risk is getting higher, and these patients are usually dependent in their ADLs and IADLs. Okay. So when we're actually performing our gait assessments, the distance of our gait assessments can be anywhere from 3 to 10 meters. It is very important, though, that we give at least 2 meters for acceleration and 2 meters for deceleration. That way, that gait speed is even as across the measured distance. We also need to be very comfortable and capable of making sure that we measure over the same distances for both the quick walk and the comfortable walk. So typically, we're going to measure our patients walking at a normal, natural speed. We'll usually measure that twice and average that. And then we'll also ask our patients to walk as quickly as they can without running over that same distance. That's going to be our max walking speed. We're going to have them do that twice as well and then average that. Our fourth aspect of frailty we want to examine is low physical activity. And I've already mentioned that quite a few times when I'm talking about the other systems. So when I was talking about reports of fatigue, decreased walking speed, all these things are kind of, again, part of that cycle. They're all very interrelated. So when a patient is more fatigued, then they don't do as much. They don't do as much activity. And that fatigue and low activity might be because of undernutrition or overall weight loss, which we're going to talk about as well. So what we know is that participation in regular physical activity is associated with around a 40% lower risk of experiencing low energy or fatigue. So that's what it's really going to come back to is these patients are very deconditioned. What we do know, if we can get these patients to engage in regular exercise, we can decrease their fatigue and we can increase their ability for physical activity. Again, when we are talking about fatigue and reduced activity, they're so interrelated. It is really hard to determine if fatigue is causing reduced activity or the reduced activity is causing fatigue, because again, they're so interrelated. Again, we'll go back to that first diagram just to see just how interrelated these systems are. So let's revisit this once again. So that decreased activity, as you can see on the left, means that we're going to have maybe a decreased maintenance of that lean tissue. So we're going to have weight loss. We're going to have sarcopenia because we're not utilizing or stressing that musculature so that it can maintain that musculature. And maybe they're not eating enough as well. That leads to decreased energy, the feeling of fatigue and exhaustion. And that exhaustion means that our patients are going to be walking slower, and they're just not going to do as much because they feel exhausted. So again, it's very interdependent, interrelated systems that we're talking about. So how do we measure physical activity of the elderly? One of the best ways is a great scale called the Physical Activity Scale for the Elderly, as you can see here. So it consists of 12 different questions that really just talk about the different frequency and duration of both leisure activities, household activities, and work-related activities over the previous 7-day period, just to get kind of a 7-day snapshot of what patients are doing on a regular basis. So this is a good way to measure overall physical activity. Another really good way to think about physical activity is a combination measure, which is life space. So life space is a measure of spatial mobility. It's defined as the size of spatial area a person purposely moves throughout his or her daily life, as well as the frequency of travel within a specific time frame. So as you can see, there's levels of 0 to 5 here, where some people aren't moving outside their bedroom. They're limited to one room. And you can see someone who's limited to one room, all the issues that might be occurring here. If they don't feel safe to even leave their room, they're probably weak. They're probably they're obviously probably have decreased gait speed because they're not even able to move outside of their room. They're probably experiencing fatigue. So you can see how this is a good way to also measure physical activity. The next is the home, and then you're talking about frequency to actually go outside the home, and then outside of the neighborhood, outside of the town, or to go anywhere. So again, that rating of 5 would be someone who's completely unlimited in their life space. So they don't really have any limitations of mobility or activity. While someone who is reserved to maybe just going outside their home a few times a week for short amounts of time, it's a good way to kind of measure overall physical activity and overall limitations. So I really like to talk about a patient's life space. All right, and the last measure of frailty that we're going to talk about is unintentional weight loss. So this is the clinical consequence of involuntary weight loss. So we usually have functional decline, infections, decubiti ulcers, exacerbations of cognitive and mood disorders, and we can even have increased use of acute and long-term facilities. So again, when patients are getting weaker, there's lots and lots of different consequences just from not getting that adequate nutrition to support themselves. And again, we talk about frailty is really a disease of energetics. If you're not putting enough energy into the system, a lot of things are not going to be able to repair and be able to deal with different stressors. So based on evidence from a large cohort study that involved 4,010 persons aged 65 or older in 11 cities in Europe, the most common independent factors associated with unexplained weight loss are those really related to food intake. So we're going to talk about some other additional factors, but a lot of the factors for weight loss are really just decreased food intake, which makes sense. So the people most at risk were ones who are eating less than one meal per day. It's really hard to maintain your weight if you're eating less than one meal a day. Those that were reported to eat less overall, those who reported a reduced appetite, those with severe malnutrition, And then again, those more physiological ones, someone with issues swallowing food. This is sometimes underreported and underobserved for a lot of people. A lot of people they're starting to lose weight, and they're saying, they don't want to eat as much. Sometimes older individuals are a little reserved and sometimes even embarrassed that they might have some issues swallowing, and that can actually be a source of anxiety. So again, these are different questions when we really need to ask our patients, try to get to the bottom of why they might be losing weight. Additional factors might be psychological factors. A lot of our patients, 65 and older, just might be depressed. And so a cross-sectional study of 68 community-dwelling older adults in Midwest USA showed that depression was independently associated with weight loss. I think that's a big telling factor. Again, a lot of times people who are depressed just aren't having that food intake, and then we know how that cycle works. Another could be social factors. So again, reduced social activity was also an independent contributor to unexplained weight loss in the older individual. So now we are seeing again how these are all interrelated. We just talked about life space, those people not being able to go out, not being able to interact with other people. Earlier in the talk, we talked about how important it was to have that self-perceived wellness, that self-perceived feeling that they're involved in their life, that life satisfaction. If that is low, people are more likely to be depressed and then more likely to eat less. And if they're going to be eating less and losing weight, it really starts that cycle once again. So as we're talking about that undernutrition and weight loss, this really plays back into sarcopenia. Sarcopenia is a topic that you will see quite a bit. We're talking about kind of natural changes that happen to individuals as they age. But one thing that we will hit on, and I'll get on my soapbox a little bit, is that a lot of it can be attenuated by exercise and proper nutrition. So again, our patients can age successfully. So let's go ahead and define sarcopenia. Sarcopenia is the degenerative loss of skeletal muscle, mass, quality, and strength associated with normal aging. It's usually at about a rate of 0.5 to 1% loss per year after age 50. A lot of what we see is replacement of muscle fibers with fat. We see increased fibrosis of the fibers. We also see degeneration of the neuromuscular junction, again blunting the neuromuscular response. The good thing is all these things can be attenuated and can respond to strength training, which I'm going to hit on very hard, that we can really prevent or decrease the rate of a lot of these changes by continually and regularly being involved in strength training procedures. So as you can see on the picture on the left, a lot of these changes. So you see that replacement of those muscle fibers with fat. See that fatty infiltrates even inside the muscle fibers. So not just outside in the decrease in overall mass, but we also see that it becomes actually embedded, kind of marbled into the different muscle fibers, which makes them a little bit less effective as well. It is because it responds to strength training that is so important to actually initiate these strength training interventions as early as possible, again, to build that muscle reserve and delay those eventual functional limitations. So if we know that our muscle mass and strength are going to decrease 0.5 to 1% per year after age 50, wow, how important it is to actually build up the mass before 50, so that with that degeneration, you have so much reserve that you can age successfully. That is why really sarcopenia is actually a disease, I feel, of younger people, because if younger people don't build the strength and mass when they are younger and have the hormonal and neuromuscular facility to do so, then they can definitely blunt or delay sarcopenia from happening and not making it so that when they do have that loss over time, so that it doesn't actually affect their function or have them functional limitations or different disabilities. So some of the things that we see with sarcopenia is a loss of strength that's going to be actually greater than the percentage of loss of total lean mass. And this is explained primarily with the decrease in those type 2 muscle fibers. The type 1 muscle fibers are actually largely unchanged. We're going to talk about that a little bit. So your type 2 muscle fibers are the ones with the myosin heads that are a little bit larger. In general, type 2 muscle fibers in general are larger. And if you remember, those are those anaerobic, very explosive, high power fibers. Now, they only stay around and stay active in hypertrophy if you're using them. So that means in order to maintain those type 2 muscle fibers fitness, you need to be doing activities that are both heavy, so it's stressing the actual musculature of those type 2, those stronger muscle fibers. So this is more heavy weightlifting. We're going to talk about that a little bit in the 75% of 1 rep max and above. And you also need to be doing things with lower weights more quickly. Again, those explosive type anaerobic activities versus those type 1 muscle fibers who are a little bit more aerobically fitness trained. Okay. What we also see is this denervation of those type 2 muscle fibers because they're not really being utilized very well, and they're actually innervated by the motor units of type 1 fibers. They essentially turn those type 2 fibers into functionally type 1 motor fibers. So those previously type 2 fibers start firing in similar fashions to the type 1 fibers. So again, we have less overall strength and we have less explosiveness. That carries over to a lot of the activities we need to be able to do, which is simply get out of a chair, walk quickly, all these different things that those type 2 muscle fibers are so important for. So again, that loss of strength is actually even more than the loss of total lean mass. But we do lose lean mass as well. So lean mass contributes up to 50% of total body weight in young adults. However, it decreases to about 25% by 80 years of age. We're talking about individual muscles. The cross-sectional area of the vastus lateralis reduces by 40%, and the total muscle fibers decrease by 25%. Again, we see loss of muscle mass exchange with that gain in fat, and we especially see that in the lower limb muscles, especially the larger muscles of the lower limb. Again, that neuromuscular changes that we're seeing, we see slowing of muscle contractile properties and that rate of force development. Again, things that we're not utilizing as much. So if we're not doing activities that require quick force development, we're going to lose some of these adaptations. So we see reduced rate of cross-bridge cycling, alterations in excitation and contraction coupling, and we see increased compliance of muscles tendinous attachments. So again, a lot of different negative changes by not stressing these different systems. Again, all of these can be addressed by doing strength training activities and power activities. One last note about the nervous system is that half of muscle mass decline with age is actually from, again, that loss of innervation that we talked about. So we talked about some of those type 2 muscle fibers. They're being uninnervated and then re-innervated by those type 1 muscle fibers. Well, also we have some that are just not innervated, re-innervated at all. So we have some of those, again, fewer motor units that are actually controlling more fibers. So some of those motor units that used to be multiple motor units innervating these fibers, we actually have fewer total motor units doing more fibers and being actually less efficient with it. However, again, this can be amenable with training. So Power et al. Found that motor unit estimates in the anterior tib in masters runners were not significantly different than the younger populations, while untrained elderly with significant lower estimated motor units. So what we're seeing is that with these people who have trained since they were young and have continued that training for a long time and been consistent with it, we really don't see these changes. It really reflects back to that old saying, if you don't use it, you lose it. And that's really what we see. Physical stress theory teaches us that if we don't utilize or stress these different systems, then we're not going to see adaptations to those systems. So this makes sense, but the evidence also supports it. So finally, what do we do about it? We're really now going to dive into the importance of exercise, which I've tried to briefly stress as we've gone through some of these things, but just how important it is to make sure that we are helping patients have successful lives, how they age successfully, and ability to enjoy their lives and be functional. So the American College of Sports Medicine recommends that for important health benefits, older adults need at least 2 hours and 30 minutes or 150 minutes of moderate intensity aerobic activities every week, as well as weight training, which they define weight training as muscle strengthening activities on 2 or more days a week that work all major muscle groups. So that's the legs, the hips, the back, the abdomen, the chest, the shoulders, and the arms. Or one alternative could be 1 hour and 15 minutes of vigorous aerobic activity instead of the 2.5 hours of moderate intensity. So again, they're basically rating vigorous activity as a 2-to-1 ratio of importance to moderate activity, meaning you can do about half the amount of aerobic activity if you do it more vigorously to get the same effect, while still recommending at least 2 days of muscle strengthening activities for all major muscle groups. So metabolic equivalence is a good way to measure overall activities. So again, with those recommendations of moderate versus vigorous intensity, those are really correlated to what metabolic equivalence these different activities elicit. So for moderate intensity, like the 150 minutes that were recommended, this is any activities that are about from 3 to 5.9 mets. So anything from 3 to just under 6 mets. As you can see, some of the activities that a person would just generally do at home actually meet a lot of those requirements. So just sweeping the carpet, gardening, playing with your dog, washing or waxing the car, playing with kids or could be grandchildren. All of those are actually moderate intensity. So when you really think about only 150 minutes of moderate intensity, that's really not that much. This is kind of a bare minimum. And then for vigorous intensity, it's anything over 6, which we're going to talk about a little bit more on the next slide with formal exercise. So again, as far as the metabolic equivalence for more formal exercise, you can see that even walking briskly doesn't really get you quite up into that vigorous intensity. We're really needing to get to weightlifting very quickly, or swimming, calisthenics, running. So these are actual activities that are going to really stress these patients. So again, aerobic dancing, heavy gardening, things that really have you breathing hard. I mean, that's really what strengthens your aerobic capacity. You have to be breathing hard for these activities to be stressing those systems for those adaptations. So next we're going to talk about resistance training programs. So it should really be stated and make sure that we know that a properly designed program with appropriate instructions for the exercise technique and spotting if necessary is healthy for older adults. Yes, of course they have to be careful. Yes, we have to take into consideration their bone structure, kind of their starting place, and it needs to progress slowly over time. But patients can reach very high levels of fitness from very deconditioned states if with proper nutrition and proper programming over time. So some of those principles of resistance training that we're going to talk about are individualization, progression, and periodization. And note that this is the same for a young athlete, an advanced athlete, or an older adult. We're talking about changes to a biological system. And yes, we do need to take some things into account with older adults, but also I think it's important that we look at our older adults as athletes. These are just senior athletes, and maybe they're starting from a very deconditioned lower state, but it is our job to safely get them to a higher level of fitness and functionality. So the first thing about our program that's going to be important is that it is individualized. So we need to make individualized assessments and individualized modifications to the program so that it properly fits the patient. You shouldn't have the same exercise program for every person that you work with. You're not doing a skilled intervention if you have the same thing. Those modifications and individualized actual exercises you do should actually correlate to what the patient is weak at or where the patient needs the most progress. They need to be monitored and designed to meet the unique physical, psychological, and medical challenges to that individual, including different comorbidities, orthopedic issues, mobility, and activity toleration. So we definitely need to make sure that a patient has been medically cleared before you start an exercise program with them, medically cleared by their doctor, that you take a full history of their orthopedic issues, any maybe cardiovascular issues, neurological issues. But after that, the patient needs to be monitored and make sure that you're doing things that are in line with their goals and what goals that they have to achieve. Again, supervision is very important, definitely to make sure that we facilitate optimal improvements in muscle strength and also balance, especially with more coordinated movements that we might have some of our patients do. Especially initially, we need to make sure that they're able to perform these in a safe manner. So progression. So one of the biggest principles in any kind of exercise, whether that be aerobic exercise or resistance exercise, is progression and progressive overload. So for anyone to make progress, they need to progressively overload the system. That just means things need to get harder over time. So overload has actually been defined as at least, at minimum, 60% of the muscle's maximum force generation capacity must be exposed to a stimulus to improve force generation. So what that means is if you want to improve force generation or strength, what you need to be able to do is move resistance that is at least 60% of your 1 rep max or your maximum force generating capacity. Okay? And of course, there is a dose response relationship. The greater the stimulus, the greater the improvement. If you continue to do things that are 60%, you probably won't get the same response as if you're doing moving weights or resistance that's about 70% of your 1 rep max. Okay? The other thing it has to meet is it has to be progressive. It has to get harder over time to continue to elicit adaptations. Your body adapts to the stimulus you give it. You have a stimulus, a recovery period, and then adaptation that occurs. And now you have a new level of fitness. With that new level of fitness, if you don't overload or progressively overload and make it harder once again, then you aren't going to have an adaptation that is going to improve your fitness once again. So it's a great diagram on the top left about meeting those two components. So those dashed mark right there is kind of the overload threshold. So the first key that we need to meet is that the stimulus we provide is overloading. So if none of those stimuli are actually above that 60% of the 1 rep max, you're probably not providing overload. Now, this is after a patient has actually got up to a reasonable level of fitness. One thing we should note is that some patients who are deconditioned, just doing anything, any activity, is probably overloading initially. But eventually, we need to start pushing higher levels of resistance. And the second component it has to meet is that it is getting harder over time. It's progressively getting harder, as you can see in that diagram. The other thing we talked about was periodization. So again, I had just mentioned in the previous slide about stimulus, recovery, and adaptation. So that's an SRA curve, but it's a good description of the adaptations we get with exercise. So the stimulus could be aerobic stimulus, going for a run, or it could be a strength training stimulus, lifting a heavy weight. After that stimulus, your fitness, which is measured on the y-axis, is going to initially decline. If you lift, do heavy leg activities one day, very highly stimulating, your fitness will actually decline, meaning the next day you probably can't even do the workout you did the day before. That makes sense. And then over time you recover metabolically from that. Your body makes adaptations, and next thing you know, that fitness level has increased. And then over time you give a new stimulus, and then you have a decrease in fitness, and then a recovery, and an increase with that adaptation. And that's really how all exercise programs should be set up. So as you can see on the bottom left, what happens over time, what we call periodization, you really need times where you're making things harder and harder and harder over time until you get to a point where you really can't do any more and patients aren't able to recover. That MRV on the left is that maximum recoverable volume. So that's kind of the amount of activity that you can no longer recover from, or your patient can no longer recover from. At that time, you need to give them some rest so that they can recover. That's called a deload period. So that's usually a week or two where they do very little activity to let their body kind of recover. They let their muscles recover, they let their joints and tendons recover, and then they can start another training process. Again, so some of the things that we need to think about is the program needs to be individualized. It needs to be progressive, so progressive overload, and it needs to be periodized, meaning it's hard for a while, progressively harder, and then you need time to deload and recover your patients. Okay, you need easier times. Again, as far as intensity, really individuals need to be working out to where they're doing 2 to 3 sets of 1 to 2 multi-joint exercises per major muscle group and achieving intensities of 70 to 85% of a 1 rep max, 2 to 3 times per week. Okay, so if we look over on the repetition matchup with the 1 rep max, the diagram on the left, you can see a 70% 1 rep max is a patient being able to do an exercise 11 times and then being at complete concentric muscular failure, okay? And then 85% is only being able to do it 6 times, which is much more in those strength ranges. So anywhere between those is kind of where you need to be putting your patients up to. I think that's very much in stark contrast to how we think to strength training with geriatric populations. When we think about using light TheraBand and light ankle weights and have them doing, sets of 15 and 20. Yes, that might be good at the beginning of a program when someone is very deconditioned, but really we need to do better for our patients and really start stressing those systems if we want them to adapt and get better. And the other thing we need to be doing is doing powerful exercises. So like I talked about, things at high velocities. And these are going to have to be done at moderate or lower intensities. So about 40 to 60% of a 1 rep max. So again, you need to be moving heavy things, and you need your patients to be moving light things quickly. And what do both of those things achieve? Again, this cycles back to those type 2 muscle fibers that we see lost the most with sarcopenia. How do we address those? Those are the fibers that are activated with very heavy tensile loading, and then those are activated when they have to produce force generations very quickly. High velocity movements. This is the power movements that we're talking about here. So it makes sense why we are addressing it in this manner. So a different way to think about working with our geriatric populations, but one that is truly going to benefit them. We really need to change the paradigm. This is a good visual representation of this. Which one is training and which one is not? Are we really doing the best for our patients by having them do 1 pound weight bicep curls for 100 reps and the patients aren't even tired? Or are we having them really do heavy functional movements safely, of course, and really stressing these systems? Okay. So now let's talk about some of the adaptations we're going to elicit with our strength training. Number one, and most notably, muscle cell hypertrophy or muscle growth. So even in individuals up to 85 years of age and older, we know that resistance training has been shown to increase skeletal muscle cross-sectional area. So our actual growth of muscles can happen up through 85 years of age, which is pretty remarkable. We also know we can have an increase in maximum motor unit recruitment. Again, that's kind of what we talked about before. If you don't use it, you lose it. So if those motor units aren't being utilized, that's where we see that denervation taking place. However, especially when we're training closer to the lower end of the 1 rep max strength, the higher percentage of 1 rep max, we're definitely going to get more of that maximum motor unit recruitment. And what is that going to turn into? Increased force generation that we've talked about. So we can see strength and power improvements again in individuals even greater than 85 years of age. We also know that resistance training has demonstrated marked improvements in both skeletal muscle power, ranging from 14% increase to even a 97% increase when we do that power training. Again, that's that high velocity resistance training. So that is, again, those lighter loads between 40 and 60%, that 1 rep max, light loads being moved very quickly. Again, targeting those type 2 muscle fibers. We also see enhanced maximum motor unit firing rates and elevated spinal motor neuronal excitability. The exact opposite of all the things that we see happen with frailty and sarcopenia when we see those losses taking place. So again, our strength training is really going to attenuate all those different losses that we might have if we're not doing it. So very important for both ourselves as individuals and for our patients. Other very important benefits of strength training is that mechanical loading is a fundamental factor for bone mass accretion, meaning to generate the adaptive responses of bone osteogenesis or formation, we need mechanical loading, and mechanical loading of a sufficient magnitude, rate, and frequency. And that's typically most adequately seen when it's loading through the long bones of the skeleton with significant forces and regularly. So again, we see the greatest skeletal benefits with resistance exercises when the resistance was progressively increased over time and the magnitude of mechanical loading was very high. Again, around 80 to 85% of the 1 rep max for maximum skeletal benefits. Again, this is that heavy loading, heavy lifting. When I showed the picture of the elderly female doing a deadlift, that's really what we're talking about here. Really challenging our patients as long as they can progress to that level in a safe, gradual manner. This is the best thing to prevent bone loss. We also know that power training maintained bone mineral density in postmenopausal women, also without increasing their risk of injury or pain. So it's definitely important for women as well because they have extra rates of bone loss due to menopause. So some additional benefits that we're seeing as well are the psychological health benefits for our older adults. So we know that resistance exercise programs have been effective in lowering both self-reported and therapist-rated levels of depression in our older adults. It's even been shown that resistance training offers a similar antidepressant efficacy as standard pharmacotherapy, meaning similar outcomes from putting a patient on an antidepressant versus just having them do resistance exercise. That is pretty powerful, especially when you combine it with all the other benefits that we've already talked about. It can also mitigate behavioral problems such as social disturbance, communication difficulty, self-care, and confusion that are associated with advanced stages of dementia. So what do we see with exercise in general that we can educate our patients on? It can improve their mood. You can have positive changes in confusion, reduced anger, reduced anxiety, improved quality of sleep, reduced tension, improved overall vigor and spatial awareness. We can see improved visual and physical reaction times and increased self-efficacy. All these benefits from resistance training. This is one of the many reasons I'm so very passionate about imploring our older individuals to be engaged in progressive resistance training activities. Besides just standard resistance training that we think of in a gym with weights or other forms of resistance, one thing I did want to mention is functional training. Again, that goes to the law of specificity. So specificity and the SAID principle is we make specific adaptations to specific imposed demands, meaning we get good at the things that we practice. And we know this from a wide range of different studies, from motor control to resistance studies. So what we really want to say is that we really need to incorporate functional training with our patients, having our patients do dynamic, multi-joint, complex movements on varied different surfaces that really mimic their daily environment and tasks that they do on a daily basis. When we do this, we can improve their ability to perform ADLs, and because we're doing very specific movements that have very good carryover to what they do on a daily basis. So trials have even shown a lot of carryover where functional training programs have shown positive effects on ADL performance that can be sustained even 6 months after the conclusion of the training. So very important that we also think about, when we're thinking about movements, make sure that they're not just strengthening movements, but they're strengthening movements that also mimic what our patients need to do on a daily basis. Next, we're going to shift gears a little bit and talk about the importance of nutrition to support the resistance activities we're doing. So there are some dietary changes that are recommended with aging, or at least considerations we need to think about. So this is the new food pyramid. It's changed quite a bit, specifically for older adults over the age of 70. And what I really love about this new pyramid is it really prioritizes physical activity and exercise as a key pillar, as you see on the bottom. Next is followed by proper hydration, which is so very important, not only for physiological function, but for cognitive function for these patients. So many of our patients have declines in overall function because they just aren't drinking enough water and are getting chronically dehydrated. So I really like the way that this is set out for our patients. The number one thing we need to talk about in regards to nutrition is caloric intake. Now, we do know, of course, that someone who is obese or morbidly obese, of course, these are things that we need to reduce calories so they get into a healthy weight recommendation. But I also want to make mention of, again, a lot of our patients aren't taking in enough nutrition, especially our geriatric patients. They have that chronic undernutrition. We have get micronutrient deficiencies, inadequate, especially levels of protein, and we get weight loss, and then that leads to our sarcopenia and all our other issues. So I definitely would like to say that it is beneficial to recommend for most individuals, unless they're battling weight, diabetes mellitus, coronary artery disease, some of these other comorbidities, an isocaloric or a slightly hypercaloric diet, meaning they're maintaining weight or just very slowly gaining weight, so that they can prevent weight loss and increase retention of lean mass. So besides an adequate overall caloric intake, the main thing we need to really be worried about is protein intake. Now, at one time, it was held that there was a possibility of higher protein intake being harmful to our patients because of possible risk for toxicity or impaired renal function. That has largely been refuted. Recent research suggests that actually a moderately high protein intake is necessary for maintaining nitrogen balance and offsetting age-related lower energy intake, decreased protein synthetic efficiency, and impaired insulin action. So right now, the IOM currently recommends for both older and younger adults that the consumption of 1 to 1.3 grams per kilogram of lean mass per day should be ingested of dietary protein, with twice weekly progressive resistance exercises to reduce age-related muscle mass. So again, all of these recommendations from all these governing bodies are saying 2 to 3 times a week you really need to be working on heavy progressive resistance activities. You need to be getting an adequate amount of nutrition to support the recovery from those, and especially making sure that we get an adequate amount of protein. However, what we know about protein intake is sadly only 6% of men age 71 and above, and only 4 to 6% of women age 50 and above are actually meeting that recommended intake level of 1 to 1.3 grams per kilogram. Here's some more supporting evidence. For men and women with sarcopenia between the ages of 70 to 79, a study found that individuals with the highest protein intake lost the least amount of lean muscle mass over a 3-year period. So we saw a greater proportion loss of lean muscle mass. The greater the proportion of fat mass, the greater the risk of metabolic imbalances and chronic disease. So we really want to prevent that loss of lean muscle mass. Additionally, loss of lean muscle mass increases a patient's likelihood of falling. That's why it's so important to maintain that muscle mass in older adults to prevent these from taking place. Again, how do we do that? Adequate amount of protein, adequate amount of calories, and proper resistance training activities. Again, a study by Hannon in 2000 found that higher protein intake was also associated with lower bone loss. Again, more support for an adequate amount of protein intake. So, what are more specific protein recommendations? And this is important to realize, is that there's kind of a threshold that we have to hit to actually initiate protein synthesis. So it's about 25 to 30 grams of protein we have found maximally stimulates muscle protein synthesis in both young and older individuals. However, we do know that ingestion over the 30 grams or about 10 grams of those essential amino acids in a single meal dose does not really further enhance the stimulation of the muscle protein synthesis. So we really need about 25 to 30 grams of good protein per meal spread out throughout the day is really your best option for recommendations. And I'm going to go a little bit more into specifics in just a second. However, we know that many older people may be consuming only just minimal amounts of protein at each meal throughout the day and not really reaching that threshold of intake. So it's kind of like that all or none principle, that really getting trace amounts of protein throughout the day that adds up to what you need isn't really what we want. We want kind of larger doses of protein spread out throughout the day. So again, you have to kind of meet that minimum threshold. And again, this is for you as well. That minimum threshold of 25 to 30 grams of high quality protein that contain about 10 grams of essential amino acids to stimulate that protein synthesis. So let's just quickly go through a functional example. In this example, we have a 78-year-old male who weighs 90 kilograms or about 200 pounds. So you multiply 90 times 1 to 1.3 grams per kilogram of lean mass. And in this, we're going to assume that the patient's weight is mostly lean mass. And that comes out to about 90 to 117 grams of protein per day. So a couple of different options for that range. Again, we need that 25 to 30 grams of protein in every meal to really get that muscle protein synthesis. So option 1 on the lower end would be to do 3 meals of about 30 grams of protein each, spread evenly throughout the day. Or if a person with a little higher appetite or higher activity level who could get 4 meals in a day, then you would recommend them doing 4 meals of about 25 to 30 grams of protein each, spread evenly throughout the day. The 4 times 30 is about 120 grams. So, that's the higher end of the spectrum. And 3 times 30 would be 90, the lower end. Either one would probably be fine and meet that minimum or maximum threshold without going over or without over satiating our patients. Next, we're going to talk just briefly about vitamin supplementation. So there's a large body of epidemiological evidence that suggests eating a rich diet, especially in fruits and vegetables, and with rich sources of vitamins, has a protective effect on development and disease. So that's where we get a lot of our recommendations for intake of fruits and vegetables for most of these nutrients. However, failing compliance with the natural source of essential nutrients in all populations are at risk for vitamin deficiency, but especially older adults. So vitamin supplements should be encouraged for those patients. Again, we shouldn't overdose vitamins. Just a regular multivitamin or specific vitamin supplements a patient isn't getting through their natural diet should be done at replacement doses, not super therapeutic doses. Those should be avoided. One vitamin I wanted to make special mention of is vitamin D. It seems like the research keeps coming out on just how beneficial vitamin D is. And now they're actually kind of terming vitamin D almost to have hormonal effects at some point. So why do we need vitamin D, and why is especially D3 so important for our patients? Well, for one reason, the skin of the elderly produces less vitamin D in general than younger people. They also spend much less time in the sun overall and are at very much higher risk for vitamin D deficiency. We also know that vitamin D deficiency is really correlated with a lot of different risk factors. Risk factors for osteoporosis, for cardiovascular disease, for hypertension, and for type 2 diabetes. So, how much should we prescribe our patients a day? It's on a little bit of a sliding scale. So for everyone from basically 1 to 70 years old, they recommend about 600 IUs. And over 70, a little bit more. Again, that's due to decreased overall absorption and utilization as we age. However, data from a European report revealed a prevalence of vitamin D deficiency up to 40% among institutionalized and or hip fracture patients, which is a major concern. So a lot of people just aren't getting that all the way in. All right, next we're going to shift one last time to our final topic, which is how do we help our patients make these health behavior changes? So the first kind of concept I want to introduce you to is the trans-theoretical model of change. And it's the idea that health behavior changes involve progress through these 6 different stages of change. The first stage is pre-contemplation stage, where there's really no intention of taking action. If you have a patient that's in this stage, it is going to be very difficult for them to get to the preparation or action phase. But again, this is our job, and we're going to give you some tools to try to help them do that and different ways that you might be successful. We also have to recognize that behavior change is very difficult. And if a patient isn't ready to buy in for any number of reasons, then you really can't help them make some of these changes. You can't be too hard on yourself. The next stage is the contemplation stage, in which the patients have intentions to take actions and they plan to do so in the near future. So they're at least planning to do it. The next stage is the preparation phase where there is the intention to take the action and they've actually started to take some steps towards that action. Finally, we have the action stage where the behavior has been changed at least for a short period of time. Then we move into the maintenance phase where that behavior becomes more normalized and regular, and the change continues to be maintained for the long term. And then finally, hopefully, we get to that termination phase where there's really no desire to return to the prior negative behaviors before. So for at-risk populations, the general rule of thumb is that about 40% of our patients that are at risk are in that pre-contemplation phase. About 40 are in the contemplation phase, and only about 20% are in the preparation phase. That means for those at-risk populations, those 40% in the pre-contemplation phase, that's about 40% of all the people that haven't started making actions aren't really even ready to start doing actions. They haven't even really had intention of doing it. So that means about 40% of your kind of difficult patients in changing behavior just aren't going to be ready to change behavior. So again, you can't be too hard on yourself. The next concept I'd like to talk into, which is going to guide us into the principle of motivational interviewing, is self-determination theory. This theory is really designed to support the patient's intrinsic tendencies. So it says that engagement and motivation of an individual is down to 3 kind of different factors. That's 1, a patient's competence, so their mastery of doing an activity. So when you think about competence, maybe in exercises, maybe we want them to exercise more regularly, and that's the intervention we want to do, or the behavior we want to change. They need mastery of it, and they want to feel like they're effective at doing it. So this is where we come into teaching the patient on how to do the activities successfully, how to perform the exercises correctly, all these different things that will increase their competence. Next, we have autonomy, having to make their own choice in their own behavior. This is where we need to really listen to our patients, and again, give them the autonomy of what activities they actually want to do. If your goal is to get someone more active and they're very interested in walking, but you really want them to do bike riding, they're probably not going to be nearly as successful because it wasn't their idea. It's not an activity that they want. So you can educate them that one might be more beneficial than the other, but you really need to listen to your patients. And then finally, relatedness, or feeling connected to others, having that sense of belonging. This is what's so great about group exercise programs and group weight loss programs like Weight Watchers, is they have a support network involved in it all together, where they really feel like you're supported by other people, where you belong and that you feel really connected. Self-determination theory really goes hand in hand with the intervention of motivational interviewing. So this is a type of general conversation used to increase a patient's motivation and commitment to making their changes. So it's really based around being collaborative, again, cooperative partnership between both the patient and the clinician or the coach. Evocation, so evoking the patient that which they already have to activate their own motivation and resources for their change. And then again, honoring the patient's autonomy. That's where we talk about kind of detachment from outcomes, but not an absence of caring, but rather an acceptance that people can do and make choices for their own lives. So there's 4 guiding principles that we talk about with motivational interviewing. First is resist telling them what to do. If you tell someone else what to do, that's a very easy way to get knowledge across, but it doesn't make that patient feel like they're doing it themselves. It takes away that autonomy that we've been talking about. So the second thing we need to do is try to understand what the patient's motivation is. What are their values? What are their needs? And what are their barriers that are keeping them from changing their behavior? To do that, we need to listen with empathy. So we really need to slow down, seek to understand our patient. Again, their motivations and potential barriers for changing that behavior. And then finally, and one of the most important things, is we need to empower them. That's the opposite of telling them what to do, is empowering them to work with them to set achievable goals and to identify specific techniques to overcome barriers. So when you talk to them about what barriers they might have to exercising, lack of transportation, maybe they have lack of money for a gym membership, that's when you problem solve with them and you say, how can we overcome these? Do you think you could get a discount at the gym if we went and talked to them? Do you think that your daughter could give you a ride to the gym when she goes 3 days a week? So helping them problem solve and overcoming those barriers to really empower them to meet their goals. And a final thing for goal setting, once again, is that kind of autonomy, that buy-in. So for older adults, setting goals through a collaborative arrangement becomes really a partnership between the individual and the healthcare professional, will really contribute to greater adherence. So how are we going to get that adherence or that buy-in to specific goals? Is make sure the goal is very specific to what the individual wants. What are they trying to get out of this? Make sure it's not just, again, a general goal that you're giving with all people, that you make it very specific to the patient and their life. And then make sure the patient helps participate in actually setting the goal. If you can empower the patient and give them the autonomy to write their own goals, they're going to be much more successful.
So you have enlightened us how a dose of physical activity or exercise is described by the duration, frequency, intensity, and mode. For optimal effects, the elder person must adhere to the prescribed exercise program and follow the overload principle of training. That is, to exercise near the limit of the maximum capacity to challenge the body systems scientifically, to induce improvements in physiological parameters such as VO2 max and muscular strength. Thank you very much, sir. May I request Professor Bindu S., Head Department of Biotechnology, Ramaya Institute of Technology, Bangalore, to introduce today's speaker, Dr. Sonia Raval, to our esteemed delegates. Over to Professor Bindu.
Thank you, Dr. Kishore. It is indeed an honor and my privilege to introduce Dr. Sonia Raval, Assistant Professor of Physical Therapy, University of St. Mary, Kansas. Dr. Sonia Raval began her academic career in India, where she earned a bachelor's in physical therapy. She then completed a master's in physical therapy, specializing in neurology. Her professional career in India included working at some of Asia's most prestigious and advanced spine, orthopedic, and neuromuscular center and rehabilitation units equipped with aquatic therapy. There, she treated a variety of patients, including but not limited to spinal cord injury, stroke, and total knee replacement. As an inveterate learner, she decided to pursue her doctorate in rehabilitation science from the University of Kansas Medical Center. She joined as a postdoctoral fellow at KUMC Kansas Center soon after she graduated from the PhD program in 2016. Dr. Raval has a wide-ranging research background that includes basic science as well as clinical research. Her doctoral dissertation involved novel projects focused on improving pancreatic islet viability and functioning that culminated into patents. Dr. Raval also has extensive clinical research experience gained while working on a large multi-center study examining the efforts of diet and exercise therapy in patients with diabetic neuropathy. She has numerous publications in reputable journals and also serves on a journal editorial board. Throughout her career, Dr. Raval has been actively engaged in teaching and mentoring students. Before joining the University of St. Mary in 2018, she held multiple teaching positions during her career in India and the United States. Dr. Raval is an AIB certified vestibular rehabilitation therapist and also a certified LSVT DIG clinician. Dr. Raval is licensed to participate in the state of Missouri. So this is a small glimpse into the excellent and prolific work done by Dr. Sonia Raval. So thank you so much for this opportunity.
Hello everyone.
Thank you, Professor Bindu. May I now request Dr. Sonia Raval, an eminent physical therapist of international repute, to deliver the lecture on physical activity for elderly people with chronic diseases. Over to Dr. Sonia Raval.
Hello everyone, I'm Sonia Raval and I am an assistant professor at University of St. Mary's in Kansas, USA. And today I will be talking about the physical activities for elderly people, and we will be touching base majorly the chronic diseases for the older people. So a little bit about my background. I did my high schooling in 1999 from Madhya Pradesh. I know it is long back. And then I went ahead and did my bachelor's in physical therapy. I graduated in 2003 and the institute was located in Madhya Pradesh as well. After that, I worked in different clinical settings, and one of the clinical setting is the Indian Spinal Injury Center in Delhi. They get a lot of neurological patients, especially the spinal cord injury patients from all around Asia. They also have a hydrotherapy pool for utilized for the rehabilitation of spinal cord injury patients. And you can see this here. This is the Indian Spinal Injury Center. Then I went ahead and did my master's in physical therapy. That was from Faridabad, Haryana, and this is the institute over here. After completing my bachelor's in physical therapy, I moved to United States of America, and from here I did my PhD as well as postdoctoral fellowship. My PhD was focused on diabetes, and my postdoctoral fellowship was focused on cancer. And this is the place where I work currently. This is University of St. Mary's in United States of America, Kansas. And I work here as an assistant professor in the Department of Physical Therapy. So today we are going to talk about the elderly people, and we will specially be focusing on some of the chronic diseases that elderly people face, and what are some of the physical activities that they can do if they have those conditions. So just a little idea about the world population. World population is definitely increasing, but the aging population, that is the people above 60 years of age, are also increasing. If you will see here on the right, in 1990, people above 60 years of age were about 0.5 billion. Today they are, in 2017, today about 1 billion. So the number has approximately doubled. Now, if we move to projected numbers of 2050, you can see this number is going to increase even more, and the aged population or older people above 60 years of age will be about 2 billion. Now let us look at these world graphs shown on the right side. The darker blue spots as well as the lighter blue spots, these ones, and these darker ones, the darker blue spots. This is about 2019, and these areas with lighter blue and then darker blue spots, they had people above 65 years of age more than 10%. In 2050, these are the projected numbers, and you can see these darker spots are increasing. And even these light blue spots are increasing in number and area. That just shows that there will be more and more areas in the world in 2050 that will have a population above 65 years of age. So in 2010, about 8% of the world population was above the age of 65 years. And in 2050, it is projected that 16% of the world population is going to be above the age 65. So the speed of population that is aging is really fast. Although in the developed countries, for example, here you can see France. It took France about 100 years to double its population above the age of 60. But in developing countries like Japan, China, Brazil, India, it will take 25 to 35 years to double its population above the age of 60 years. So the world definitely is in the phase of demographic transition. And earlier we have always seen that there were more newborns than people above the age of 65 years, if you see here. But as the years are passing by and our aging population is increasing, you can see that there is a trend where you would actually see that the aging population is going to suppress the number of newborns in the world. So let us talk about India. The trend follows the similar ways as it is in the world, that aging population is increasing. And if you follow this purple line, you can see that a number of people above the age of 65 years are constantly on the rise. In one of the research, I found that in 1951, there were about 20 million people in India who were above age 60. In 1991, there were 57 million people, and this number is projected to increase to about definitely more than 300 million people above the age of 60 years in 2050. And all this, definitely healthcare system have to be ready for this increase in number. 75% of elderly people living in India still live in villages, and out of them about 48% of elderly people are women. And according to this study done in 2008, about 2 lakh people living in India are 100 years or older than 100 years. If you look at this chart on your left, you will see, so this graph here, please focus here. This graph talks about 50 people above 55 years of age, and this graph talks about which diseases are more common. So if you'll see this graph, you'll find that these are the acute cases or acute conditions or diseases. These are chronic diseases, these are accidents, and these are not really determined. So if you follow this graph, you can very clearly see that people above 55 years of age are more prone for chronic conditions. And there was a study done by Indian Council of Medical Research, and this study kind of lists down the different common chronic diseases that elderly people face. Out of that, they listed hearing and vision problems as the top ones, followed by hypertension, and then they also noted down these other chronic diseases that they found in elderly people. Those are heart diseases, cancer, diarrhea, chronic cough, respiratory disorders like asthma, other metabolic disorders like diabetes, imbalances in their lipid profile leading to dyslipidemia. Their cholesterol levels were not within the normal levels. And so today we are going to talk about some of these conditions like diabetes, hypertension, and then we will also be talking about one of the other common neurological condition, that is the Parkinson's disease. In this section, we will be talking about hypertension. Hypertension affects more than 1 billion people around the world, and it is responsible for 1 in 8 deaths worldwide. So more than 27,000 people die each day because of hypertension. And the fact is that 50% don't even know that they have hypertension. Prevalence of hypertension in men is about 24%, and in women it is about 20%. But as the age increases, above 60 years of age, the prevalence actually increases to more than 60%. While we are talking about hypertension, we have to talk about blood pressure. Hypertension is basically increase in blood pressure. What is blood pressure? Blood pressure is the force that is exerted by the circulating blood against the wall of the body arteries. Blood pressure is written as two numbers, systolic blood pressure and diastolic blood pressure. Systolic blood pressure is the pressure in the blood vessels when the heart contracts. And diastolic blood pressure is the pressure in the vessels when the heart rests between the beats. So hypertension is diagnosed as having a reading above 140 by 90 on 2 different days. The majority of the causes of hypertension is the primary hypertension. That means that in 95% of cases, the cause is either going to be genetic or lifestyle factors such as high fat diet or salt diet and doing less physical activity. But there are about 5% of cases where there is secondary hypertension. That means there is increase in blood pressure, but that is not because of either genetic or lifestyle factors, but that is because of some other disease like the blockage in the renal arteries or excessive hormone secretion, that is the aldosterone secretion, or a patient unable to sleep, or some kind of chronic kidney disease. Here are the blood pressure categories defined according to the American Heart Association. American Heart Association says that blood pressure is normal when systolic is less than 120 and diastolic is less than 80. It is defined as elevated when systolic blood pressure is between 120 to 129. Stage 1 hypertension is defined as blood pressure between systolic blood pressure between 130 to 139 and diastolic between 80 to 89. Stage 2 hypertension is defined as blood pressure above 140 or higher and diastolic blood pressure 90 or higher. Hypertensive crisis is defined as blood pressure higher than 180 and systolic pressure higher than 180 and diastolic pressure higher than 120. Hypertension is also called as silent killer. It is called a silent killer because it can lead to many different complications which can be really fatal. It can lead to stroke. High blood pressure can cause the blood vessels in the brain to burst and leading to stroke. It can also damage the vessels of the eye, leading to vision loss. Hypertension can make the heart work harder, and when the heart works harder, it can increase its size, it can get hypertrophy, and ultimately there could be heart failure. It can also lead to heart attacks by damaging or blocking the arteries. Hypertension can also cause kidney diseases. It can damage the arteries around the kidneys and can interfere with the ability to filter the blood. It can also lead to some sexual dysfunctions like erectile dysfunction in men and lower libido in women. Here are some of the very important things that have been listed down by American Heart Association and American Stroke Association. And these things have really proved to work to improve the blood pressure. First is the weight reduction. If a person tries to reduce their weight, actually that can help with lowering down their systolic blood pressure by 5 millimeters of mercury. American Heart Association also emphasizes on the eating plan. And for that eating plan, they say that there has to be diet rich in fruits, vegetables, but diet low in fat and also low in dairy like milk products. And we will be discussing about some of these points later in the slides in greater detail. Also, restricting sodium intake to less than 1500 milligram of sodium per day can actually lower your blood pressure to again 5 to 6 millimeters of mercury. Physical activity has proven to be really helpful with reducing the blood pressure. Also, lowering down the alcohol consumption. Not taking more than 2 drinks per day for men and 1 drink per day for women can also help reduce down the blood pressure by about 4 millimeters of mercury. So physical activity have a lot of different benefits. Here we are talking about hypertension. Definitely it helps reduce the hypertension by 5 to 7 millimeters of mercury. And also the effects with exercise can be seen just with, like one of the study which was done which showed that you can see the benefits within 3 exercise sessions. And the duration of the exercise session, if patient is not able to do or elderly person is not able to do more, it could be as short as 10 minutes. And the intensity of exercise could also be really low. So it is not only helping reduce the hypertension, but it also helps lower the progression of any kind of cardiovascular disease, because it will help balance your cholesterol levels, the lipid profile. So it is also helping prevent any cardiovascular disease. And with physical activity, definitely you are lowering your weight as well. And later we will see that physical activities will also help reduce the diabetes and also help reduce the glucose levels in the blood. So here are the recommendations from American College of Sports Medicine. And they recommend doing aerobic exercise, resistance exercise, as well as flexibility exercises for people who have hypertension. And in the table here on the right, they have mentioned the 3 different types of exercises that they recommend and their frequency, intensity, time, and also the type. So they recommend definitely aerobic exercise at least 5 times a day and preferably 7 times a day per week. Intensity of aerobic exercise should be moderate, and you can monitor the intensity of exercise with the help of heart rates or also with the help of the rate of perceived exertion scale. And on this scale, you should be at the level of 12 to 13. We will discuss about this scale more in our next slide. The time recommended is at least 30 minutes per day. of either continuous, or you could just keep doing little bit and then accumulate to 30 minutes in a day. Then the type of aerobic exercise, usually aerobic exercise, they are prolonged, they're rhythmic, they use like large muscle groups like walking, cycling, and swimming. Resistance exercise should be done at least 2 to 3 days per week, and you could do 2 to 4 sets of 8 to 12 repetitions, and it could be either free weights or body weights or resistance machines could be used. Flexibility exercises more than 2 to 3 times in a week, and stretching should be done to the point of feeling slightly discomfort. Hold the stretch for 10 to 30 seconds, 2 to 4 repetitions of each exercise. And any type of stretching could be used. It could be static, it could be dynamic, or it could be some neuromuscular facilitatory stretchings. So as I said, that how would you know that you're doing a moderate intensity exercise? So that could be done with the, or calculated or known with the help of heart rate reserve here, which says HRR, and I've described here heart rate reserve. So you can measure the resting heart rate of the patient in the morning, and then you could measure their maximum heart rate by calculating 220 minus their age. So you know their maximum heart rate was 220 minus their age. You can calculate the resting heart rate while they're resting, maybe early in the morning, and then you can calculate the heart rate reserve. So while they do their exercise, they should be around 40 to 60% of their heart rate reserve. And whenever these patients do start with any kind of exercises, there should be a proper warm-up for at least 10 minutes. And this warm-up should actually be longer if the patient is older and has been inactive for a long time. There should be a proper cool down as well. And there should not be any stopping of exercises too quickly, otherwise there could be sharp drop in blood pressure, and which could be really dangerous. So here is the rate of perceived exertion scale that I was talking about. You can print this scale out and then have in front of yourself, or if you are working with a patient, have in front of whoever is exercising, and you can keep asking them with the exercises, how do you feel? How do you feel? You keep asking with the patient or whoever you are making them exercise, or yourself. And if it is somewhere around 12 to 13 here, somewhat hard, if you feel that the exercise you're doing is somewhat harder, then you are doing a moderate intensity exercise. And here, if somebody says very hard, here actually after that it is going to be a vigorous exercise. Another way to figure out if it is a moderate intensity exercise is these aerobic exercises definitely will make your heart rate go up, and when your heart beats faster, you will also be breathing more harder. But you should still be able to talk if it is a moderate intensity exercise. Here are some of the examples of moderate intensity exercise, like brisk walking, just at home gardening, or going for a hiking, dancing. You could do some cycling, just active recreation, and swimming. So whenever you're doing all of these activities, if you are able to still talk, that is a moderate intensity exercise. There are definitely some precautions that needs to be taken while exercising with high blood pressure. Whenever the blood pressure is above 200 for systolic and 100 for diastolic, definitely physician clearance should be obtained. You should make sure from the physician that it is safe for the patient to exercise, or any elderly person it is safe for them to exercise. Whenever the blood pressure goes above 250 systolic and above 110 for diastolic, absolutely no exercises should be done at this point. So the American Heart Association also recommends lowering down the weight, and it has been seen that if there is 3 to 5% or more weight loss can actually result in different benefits, like there will be reduced blood glucose levels, triglycerides, lipid profile will be better for the patient, there is going to be reduction in blood pressure, and also there would be improvement with the blood cholesterol. So here are some of the recommendations made by the American College of Sports Medicine. And they say again, a combination of aerobic resistance and flexibility exercises. Aerobic exercises at least 5 times a day, but here the intensity now can be made from moderate to actually patient can also do vigorous exercise if possible. And again, 30 minutes per day is total of 150 minutes in a week. And again, including larger muscle groups for aerobic exercise. Resistance exercise could be again 2 to 3 times a day with machines or with free weights, and also supplement that with the flexibility exercises. So now for weight loss, we talked about the moderate intensity exercise as well as vigorous intensity exercise, whatever is possible. So moderate will make you breathe harder, but you'll still be able to talk. But vigorous intensity exercise will push your body even further, and you will actually begin to sweat, and you won't be able to talk much without getting out of your breath. And here are some of the examples of vigorous intensity exercises. So running, walking a hill or climbing a hill, fast cycling, doing some aerobics, fast swimming, doing competitive sports like football, volleyball, hockey, and carrying or moving heavy objects. Those would be your vigorous activities. And if you want to look in your rate of perceived exertion scale or the Borg scale, on that scale it would come around at the level of 14 to 17. That is going to be your vigorous activity. So we have talked about healthy eating and healthy diet. Diet does help with lowering down the blood pressure. In order to maintain healthy heart, vegetables, fruits, and whole grains should be included in your diet. Also, fat-free dairy products, proteins, as well as healthy fats should be included in your diet. You should limit any sugary, salty food, any processed foods, limit any hydrogenated oils or tropical oils, and just try to include as many food groups you can. So different vegetables, different fruits. And on the right side here in the table, you can see the different food groups and their daily servings that are recommended if someone who is on a 2000 calorie per day diet. So about 7 to 8 servings of grains, and try including whole grains, vegetables 4 to 5 servings, fruits 4 to 5 servings, low fat about 2 to 3 servings, proteins, lean meats, fish 2 or more, then nuts, seeds, and beans 4 to 5 per week. Fats and oils, the healthy ones, 2 to 3 servings, and then you're allowed to have some sweets, 5 per week. And here are the different serving sizes for each food group if you are looking for the daily servings and the serving sizes. So one slice of bread will have 1 serving from the food group or the grain, from the food group which is the grain part of the food group. It is recommended to include as many different varieties of foods as possible. So just try to have more color to your food. Include fruits and veggies from different colors and families, like blue, purple, which have blueberries, blackberries. Then include from red and pink, like beets, cherries, cranberries. From green, like the broccoli, the cucumbers, green beans, etc. And then from orange family, like orange peppers, papayas, peaches, pumpkins. So include as much color as you can into your plate. We will now move on to talking about diabetes. Diabetes is another debilitating and chronic disease. About 422 million people have diabetes around the world. That is 1 person in 11 people. Diabetes can cause more than or around 1.5 million deaths. Table on the left shows the different countries and their ranking with respect to number of people with diabetes in 2000 and in 2030. In 2000, India had about 31 million people who had diabetes, and in 2030, India could have approximately very near to 80 million people with diabetes. In India, China, and USA are currently leading with the number of people that are suffering with diabetes in these countries. As we are concentrating today on our older population, you can very clearly see in this graph that diabetes increases as the age goes up. Pancreas, which are located in the abdominal cavity, are the major important structures that help maintain the blood glucose levels and help controlling diabetes. So in this figure, you can see the pancreas. These are our pancreas and a zoomed image of these pancreas. They contain different types of structures and cells. These ones surrounding, they are called as the exocrine cells, and these ones are the endocrine cells or the pancreatic islets. These pancreatic islets have different types of cells. The two most important ones are the alpha cells and the beta cells. Alpha cells, they increase the blood glucose levels in our body, and beta cells, they decrease the blood glucose levels in our body. So beta cells are very, very important. Beta cells are the ones that help decrease the blood glucose levels and help maintain blood glucose levels and not develop diabetes. But in diabetes, it is those beta cells that are affected, and hence person cannot decrease their blood glucose levels. Diabetes is a chronic disease and it is characterized by increase in blood glucose levels. So in our body, about 70 to 100 glucose levels are considered as normal. And pancreas and the beta cells of the pancreas especially help us maintain the blood glucose levels. So on figure on the left here talks about the hemostasis or the maintenance of normal level of blood glucose levels and how does that take place in our body. When we eat food, the blood glucose levels, it rises. When it rises, the beta cells of the pancreas, they release insulin. This insulin helps glucose that is circulating in our blood and which is more in quantity, helps that glucose to get inside the different cells of our body for energy, and extra is stored in our liver, and that's how the blood glucose levels, they decline. Now if there is low blood glucose level, suppose you have not been able to eat well, the blood glucose levels will go down, and these blood glucose levels will cause another type of cells in the pancreas, that is the alpha cells of the pancreas, to release another hormone called as glucagon. This glucagon will break down the glucose levels or the glucose that was stored in the liver and release into the blood. That will cause an increase in the blood glucose levels, again trying to maintain the normal blood glucose levels of 70 to 100. When the beta cells of the pancreas are not able to maintain the normal amount of blood glucose levels, then it results in diabetes. There are two different types of diabetes, type 1 diabetes and type 2 diabetes. Type 1 diabetes is the one that is because of the deficiency of insulin. That is why it is called as insulin dependent diabetes mellitus. Type 2 diabetes mellitus, it initially does not start because of the insulin deficiency. It starts because the cells of the body are not able to utilize the glucose. That is the reason it is also called as non-insulin dependent diabetes mellitus. Let us look in little detail about the pathophysiology of diabetes, and especially type 1 and type 2 diabetes. So normally, as we said, that whenever you eat carbohydrates or your food, the cells of the pancreas, they release insulin. This insulin goes to the different cells of the body and helps glucose go inside the cells of the body so that the cells of the body can utilize glucose as the source of energy. But in type 1 diabetes, the beta cells of the pancreas are either not able to release insulin, or these cells are dead and cannot release insulin. If there is no insulin, the glucose will not be able to get inside the cells, and glucose will stay out in the blood, leading to increased blood glucose levels. In type 2 diabetes, there is insulin in the blood, and there is insulin that is produced by the pancreas. But for some reason, this insulin is not able to function well. When it cannot function well, glucose still cannot go inside the cells. So there will be more glucose in the blood, as well as there will be more insulin in the blood. And your pancreas keep on thinking that there is more glucose, so it has to produce more and more insulin. So there will be more and more insulin in the blood, but insulin is not able to be utilized well. So it just keeps floating there. So there's more and more insulin in the blood, and there is more and more glucose in the blood. And ultimately, these beta cells that produce insulin, they will die and say, I cannot produce any more insulin. So they are not able to produce more insulin, they die, and now there is deficiency of insulin, but that will take place later in the stage. Here is how a patient can present with the diabetes. They would have frequent urination, they would go to restrooms often, and frequent urination is called as polyuria. They will be fatigued. There is going to be weight loss, but this weight loss is specifically, this happens in type 1 diabetes. Patient is going to be hungry. That is also very characteristic of type 1 diabetes. Patient is going to be thirsty also a lot. That is called as polydipsia, the thirst. If the blood glucose levels remain elevated for a longer duration of time, they can lead to different complications. Some of the complications are listed here in this figure. Increased blood glucose levels can affect the arteries of your body, leading to hypertension. They can also affect the arteries of the brain, leading to stroke or hemorrhages. Vessels of the eyes can also get affected, leading to retinopathy and cataracts, and also visual loss. It can affect the vessels, or it can also affect the heart, leading to ischemic heart disease or myocardial infarction. It can affect the GI system or gastrointestinal system, leading to diarrhea, constipation. It can affect the urinary system as well, leading to infection as well as erectile dysfunction in males. It can affect kidneys, leading to nephropathy as well as chronic kidney diseases. Atherosclerosis can also take place. In this, the vessels of the limbs are affected, and there won't be good blood flow in the limbs, especially your distal extremities, especially the feet. And if there is less blood supply over there, it can lead to damage or death of the tissues in the feet, leading to gangrene, and finally the patient might have to get amputated or the feet removed, and prosthesis can be fitted if the atherosclerosis is too bad. It can also affect the sensory as well as motor nerves. If motor nerves are affected of the limbs, the muscles are going to be weaker. If the sensory nerves are affected in the limbs, patient will not be able to feel any sensation. If the patient cannot feel any sensation, for example, if they are walking and they hurt into something that was sharper, they will not know. And that can constantly lead to development of these ulcers in the foot. So foot inspection is very important for people with diabetes. Every single day they need to see if there is any ulcer formation or if there is any injury, they need to take care of their feet as well. So you see that so many complications that can take place because of diabetes, and these complications are the major cause of morbidity or dependence that these patients have on others for carrying out their daily activities. When we talk about diabetes, there are three major big areas that are helpful for the treatment of diabetes. First is the medications. So patient will be on insulin if they are type 1 diabetes, because you know that in type 1 diabetes there is a death of beta cells and there is insulin deficiency. So they have to be given insulin so that they can lower the blood glucose levels. In type 2 diabetes, initially there is no deficiency of insulin. It is just that the insulin is not able to function well. So they are not initially on insulin, but they are on other drugs such as metformin or tolbutamide. And later when the beta cells or the insulin cells are fatigued and then they start dying, at that time they could be put on insulin. Diet plays a big role in treatment of diabetes, and also exercise have proven to be very beneficial, not only in maintaining the blood glucose levels but also in lowering down the medications that they might need to take to control diabetes. So here are the recommendations from American College of Sports Medicine. Again, they say a combination of aerobic resistance and flexibility exercises for patients with diabetes as well. Aerobic exercise has shown to be very helpful in lowering down the blood glucose levels. So they say 3 to 7 days per week, again moderate to vigorous intensity exercise, total of 150 minutes per week of moderate intensity or 75 minutes per week at vigorous intensity exercise for type 1. For type 2, they say 150 minutes per week of moderate to vigorous intensity exercise involving larger groups. Resistance exercise, at least 2 consecutive days per week, maybe 3, and at least 8 to 10 exercises with 1 to 3 sets of 10 to 15 repetitions. Flexibility exercises, more than 2 to 3 days per week. So we see that these different exercises not only help lower the blood glucose levels, we have seen that these different types of exercises have also help in hypertension, lowering down the blood pressure. Along with that, cardiovascular risk factors will be reduced, triglycerides or lipid profile will get better, then cholesterol levels will be lower, and in general exercises have always shown to improve the mental health. You feel more energetic, you feel mentally also more healthier along with these many physical benefits. There are some precautions that need to be taken while a patient with diabetes is exercising. So exercises will lower the blood glucose levels, and they are also taking the medications like insulin or metformin that will also help lower the blood glucose levels. Sometimes while these patients are exercising, their blood glucose levels can actually go down to the dangerous levels, and it could be fatal. If blood glucose levels goes below 70, then patient will start to have some symptoms. They might start to sweat, feel weak and shaky, and anxiety. And if it goes down to even lower levels, then they could have seizures and coma. So there needs to be a change in insulin when they take insulin or when they take their medication. Either the dose of the medication needs to be reduced, or the patient should take more food or more carbohydrate before performing any exercise. Here are just the guidelines if the patient should reduce the doses of medication or have carbohydrate. So every time when patient with diabetes exercises, their blood glucose levels should be checked before the exercise. If their blood glucose levels is below 90, then they should ingest some amount which is about 50 to 30 grams of carbohydrate. This could be just any juice, any candy that has about 15 to 30 grams of carbohydrate. If they are between 90 to 150, then they can have carbohydrate snack right at the onset of most exercises. Then if they are above 150, then there is no need to give them a carbohydrate snack before the exercises. But while during the exercise they go below 150, then you can give them a snack. Then if the blood glucose levels are 250 to 350, or if they are above 350, then you should always check for ketones in the urine or the blood. If the ketones are present, then there should be no exercise at all. If ketones are not present, blood glucose levels are below 250, then they could do mild to moderate exercise. And if the blood glucose levels are greater than 350 and no ketones are present still, avoid any intense exercises, just initiate mild to moderate and until the glucose levels have come down a little bit. So there is like a range. If there is hypoglycemia, then you have to take a lot of precaution. You should not be exercising. Give them a snack so their blood glucose levels comes up. If they have too high blood glucose levels, like above 250, 350, you have to be very precautious. Just do mild, moderate intensity exercise until their blood glucose returns to within that, that range, maybe at least less than 250 or 350. And if they have ketones present, for the ketones, they have a stick, like a blood glucose. There is a stick that you can check for the ketones in their blood or in the urine. If the ketones are present, that means they are again, their body is not functioning well. That could be dangerous for the patient. So there are a lot of precautions that needs to be taken if patient with complications that have resulted from diabetes is exercising. If they have any sort of eye involvement or eye damage because of high blood glucose levels, then precaution should be taken that no excessive or intense activity is done, because if any intense or excessive activity that can increase blood pressure is done, that can result in even more eye damage. If patient has any orthopedic limitations, then make sure that proper warm-up cool down is done before after the exercise, as well as exercises to strengthen the muscles is done. And no, again, sudden exercises should not be done to avoid any more damage to any joints or muscles. If patient has kidney disease, then again, you cannot do any vigorous intensity exercises. It has to be low moderate intensity exercises. For different cardiovascular diseases, if patient has any, there should not be vigorous intensity exercise anyways. And if patient has a myocardial infarction or damage to the heart muscles, then the exercises should be done really supervised in a supervised rehabilitation program. And always start from low to moderate intensity exercise. Even if the patient has had stroke, start from low and then move up. If patient has any nerve disease, like there is sensory nerve involvement and patient cannot feel anything, then patient will develop ulcers. So daily inspection of the foot is advised to the patient, and care must be taken that you do not cause any more damage to the tissues where there is no sensation, because patient will not be able to feel it. And proper care of that area by daily inspections and having appropriate lotion, not keeping the skin dry, and making sure no fungal growth is there as well. Diet is an important part of the diabetes management, and there are different ways how patient can control how much and what they are eating. One is the diabetes plate method. This is recommended by American Diabetes Association as well. So they say that you should have start from a plate that is maybe start from about a 9-inch diameter plate, and on one half of the plate have non-starchy vegetables that do not have a lot of carbs. Then have 1/4 portion of the food that are carbohydrates, more preferably the whole foods, so that they have complex carbohydrates rather than simple carbohydrates. And then have 1/4 portion of protein. And then along with that have a low calorie drink or preferably water. So this method just allows you to not worry too much about counting each and every calorie in each and every food. You could just divide your plate into these 3 sections and put the food accordingly. Here are some of the examples for non-starchy vegetables like cauliflower, cabbage, carrots, okra, green beans. Carbohydrate foods could be always have whole foods for the carbohydrate, like whole grains, whole brown rice, whole oats, quinoa, whole grain pasta, fresh fruits, dried fruits, potatoes, pumpkin, milk, yogurt, and some protein foods like chicken, eggs, fish, beans, lentils if you're a vegetarian. One thing always to keep in mind in patients with diabetes is that you have to monitor their blood glucose levels before, after, as well as during their physical activity. And we have discussed if the blood glucose are really low, you would want to consider giving them something to eat before they start exercising. But if the blood glucose levels are too high, you should not be exercising and taking further precautions. Always consultation should be done with the physician if you are planning, or if any diabetic patient is planning to do any sort of exercises. In this section now we will be talking about the Parkinson's disease. This world map shows the prevalence of Parkinson's disease. So in 1990 there were about 2.5 million people with Parkinson's disease. In 2016 there are more than 6 million people with Parkinson's disease, and in this graph you can see the red orangish areas, they have more people. These countries have more people with Parkinson's disease. India, approximately in 2016 there were about 575,000 people living with Parkinson's disease. There is a structure in the brain. This one here, this is called as basal ganglia. This basal ganglia consists of different types of other structures in the brain, and these structures have nerve cells that release dopamine, and those nerve cells are damaged and they do not have enough dopamine, and that results in Parkinson's disease. This is how a typical patient of Parkinson's disease will present. They have a lot of stiffness, they have rigidity, their stooped posture, they are flexed, stooped posture, they're rigid, their elbows are flexed, their hips are a little flexed. They can have these resting tremors. While they're resting, their hands will be moving like this. These are called as the pill rolling resting tremors. And they are not very stable, so they can also have a fall. Here are some of the other symptoms how they can present with. So they will be slow. Their motor performance is going to be slow. They'll be slow in doing any task. Their writing is really small. Their face, they do not have any expressions. It's like a mask face. They do not have expressions. They are very hesitant to start a movement, and then they can also freeze while they are doing any movement. For example, while they are walking, they'll freeze. They are slow at learning, and if you tell them to do 2 different things at a time, like walk and count, they will get slower. Their posture is really stooped forward. They have kyphosis and they have a risk of fall. Their thinking is also slowed, and they can have some impaired memory too. They can have pain. They could also have loss of smell. And because of loss of smell, they have difficulty maintaining a healthy diet because they do not feel like eating that much because they cannot smell the food. They can also have difficulty swallowing. Their speech is also very slow and they speak in just one tone. They cannot differ their tone. There's one tone and slow speech. They can also have constipation. They can have increased oil secretion. Their chest expansion is also limited and their heart function could be reduced as well while they're walking. If you look at them, their arm swing is reduced. They take small steps and they also have difficulty. These are some of the treatment techniques that have been or physical activities that have been utilized in the treatment of Parkinson's disease. Patient, because they are so stiff, they are encouraged to do some relaxation exercises. So you could also do some yoga. Yoga does do some relaxation. And some other like rocking, like rocking in the chair, that can also help provide them some relaxation. Some range of motion exercises, doing some flexibility, stretching, and for strengthening, some resistance exercises and also breathing exercises to help with their chest expansion. Because of all the different impairments that they can have difficulty moving in the bed, sitting in the bed, sitting to standing from the bed, and then standing and walking. So all of these areas, some physical activities could be done. Therapists would usually teach them how to move in the bed, side turning to the left, to the right, and then from supine lying to sitting in the bed, then sitting to standing. And then when they stand, you can do some balance exercises. So like, standing with 2 feet, then standing on 1 feet, standing with a wide base of support, then narrowing the base of support, or aerobic exercises could also be done. And here in this figure, you can see the therapist is trying to do the balance exercises, is making the patient sit on this TheraBall. And here are some resistance exercises shown for the patient because they have difficulty turning and doing rotations. So some exercises that help them rotate. As they have hard time with walking, definitely walk training is very beneficial for these patients. You can make the patient first stand, then standing with the help of support, then they stand without support, then they do their weight shift while standing, then they step forward just one step, then they step backward, then they do side steps, then they finally move forward, then turning, and then you can increase their speed and duration of walking. And also while they're walking, then gradually you can tell them to do counting or do some other task. I would like to talk in brief about some of the exercise programs that they follow here in the United States for Parkinson's patients. And one of them is the LSVT big. This LSVT big program, this is very intensive program. This is based on research, and what they say is that the movements get slowed in Parkinson's disease. They're smaller, they're less. Patient takes small steps, they do smaller movements. So they try to encourage the Parkinson's disease patients to bigger movements. So that's why they call it as LSVT big. So, but this is only done if you are certified by them, and they have a very set protocol, like 4 consecutive days for 4 weeks. There has to be 16 sessions and each session is like an hour long. There are a few principles on which their program is based on. They say that the program should be really intensive. They say that the exercises should be complex and there should be a lot of repetitions of exercises so as to cause any changes in the brain. Also, they talk about the specificity, that the exercises should be very specific to what kind of an improvement does the patient want. If patient wants to improve their gait, then the exercises should be concentrated to their walking gait. And after always, whenever there is a reward, after you do the exercises or after they improve, it definitely helps with the brain changes as well. This is about one of the patients who had Parkinson's disease and is 71-year-old, had difficulty walking, slowness. He had slow movements. He has been falling. He used to like freeze while doing any activity, especially walking. And this patient was given this LSVT big program, and in next video we'll see the changes that he had after the LSVT big program. Here in this video is what you can see, that patient walking before and after the LSVT big program. So on this side here is the before LSVT big program. You can see he's taking small steps, and here in this one you can see he's taking big steps. His arms are swinging and he can move more faster. So in this program, they do different sorts of things. They have exercises that patient needs to do every single day, like forward stepping, side stepping, backward stepping. And then they also do the different functional movements, like they'll do sit to stand, you could do rolling in the bed, sit to stand, whatever difficulty the patient has. And then they do then they train for some other activities, whatever is their favorite, like playing golf, or they have difficulty getting in and out of the car. And also these patients get daily exercises, homework that they have to do it for all 30 days. Another program that is very popular in United States and Canada as well as in Australia is the Nordic walking, or the urban poling. So they have these poles, and they take the help of these poles and then they walk. So it has been found that if you do pole walking, there are many different muscles in your body that are active while you walk with the poles. So you are holding these poles and you're pushing the poles on the ground as well as you're walking forward. So you're working your upper body as well as the lower body. So there are different benefits that they say pole walking has. It is a full body workout. There is increase in the strength of the core and the upper body muscles. It increases the cardiorespiratory fitness. It also improves your metabolic profile. That means it helps with the triglyceride levels, cholesterol levels, the lipid profile in the blood gets better. And also it increases the blood flow. And this can be used in many of the conditions. Some of the conditions we have discussed. So like diabetes, also it has been shown to be helpful. With obesity, it has shown to be also helpful. And Parkinson's disease, definitely we are discussing right here about it. But it also is beneficial for your heart health if you walk that when you do a full body workout. And it has also been seen to be helpful with cancer, rehabilitation of cancer patients, as well as for the patients who have ear and balance problems. So different studies have been done on pole walking or Nordic walking and Parkinson's disease. On Parkinson's disease, it has been really searched well. So it has shown to improve the aerobic capacity, posture, cadence. Cadence is the number of steps per minute. Then quality of life in Parkinson's disease patients, it has shown to improve balance, mobility, coordination, gait, strength, and as well as other symptoms, like it has shown to improve mood, depression, cognition, as well as help with fatigue. You can see here on this slide how walking with the poles helps with posture and arm swinging for Parkinson's patients. Another therapy that is gaining popularity here in United States is the boxing therapy for the Parkinson's disease patients. So boxing, this is a form of high intensity exercises and involves pretty much all the regions of the body. And the type of boxing that is more popular here for Parkinson's disease is the rocksteady boxing, but it should be performed by the trained coaches. Improvement have been seen with the strength, balance, as well as the walking, gait, the distance that could be walked, the velocity, quality of life, as well as hand-eye coordination. Here is the video that shows some of the aspects of the boxing therapy, and you will see here in this video some of the patients doing the boxing therapy.
When you put on those gloves, you feel big and strong.
When you put on those gloves, you feel big and
They're really
strong.
dedicated. The Parkinson's folks work
They're
their
really
tails off.
dedicated. The Parkinson's folks work their tails off.
What we do is it's circuit style boxing training. And the idea, the important thing is forced intense exercise.
The important thing is forced intense exercise.
Parkinson's is a movement disorder, and the folks that end up being most afflicted by it have a hard time actually moving. So one of the things that you have to try to do is kind of delay that.
One of the things that you have to try to do is kind
The
of
first
delay
signs I
that.
had were tremors, but my movement so far has been pretty good.
My movement so far has been pretty good.
It seemed like an opportunity to come into a class like this where you for an hour and a half of intensive exercise.
For an hour and a half of intensive exercise.
The idea is to have them get away from those small movements. So that's why boxing is such a big fit. When you have Parkinson's, all of a sudden your steps get smaller, your gait gets real small. You might not realize it as someone with Parkinson's that your feet are shuffling along, but they are. And that's why boxing is so great. You have to, when you put on those gloves, you feel big and strong.
When you put on those gloves, you feel big and strong.
And it's not just physical exercise, it's mental exercise.
And it's not just
Like
physical
they
exercise,
teach you to count, you have to talk loudly, you have to remember counts. We do little drills that are verbal kind of drills. Force you to use your memory and then you speak loudly. Some of the drills that we do loudly might consist of somebody yells as loud as they can.
One, two, three, rock steady! Give each other love, you guys all deserve. Give each other love, you guys all deserve.
So it is a pretty intense exercise, and they usually do it in groups because working in groups also provides them some encouragement. There are a lot of famous personalities who have had Parkinson's disease, and one of the quotes said by Muhammad Ali, who himself had Parkinson's, is my favorite, and that is, the only limitation one has are the ones they place on themselves. So in a nutshell, there are different benefits of exercises. Exercises will help maintain healthy weight, manage stress, improve quality of life, help with type 2 diabetes, cardiovascular disease. It's going to lower down the risk factor for cardiovascular diseases. It is going to help with help with balance and prevent any falls, help with mental health, depression. Not only that, it's going to help with joint, back pains, and it is also beneficial for cancer patients. It also help improve sleep as well. So there are a lot of different benefits, physical activity and exercises and just being active. In older people who are otherwise healthy and do not have any other medical condition or do not have any special precautions, they are recommended by American College of Sports Medicine to do any moderate intensity aerobic activity, at least 150 minutes per week. And if they cannot start with 150 minutes per week, they can just start with 5 minutes a day. And it should be supplemented 2 days in a week by the muscle strengthening activities. So older adults who are otherwise healthy, this is the recommendation, but all the exercises, physical activity that anybody does or older people do, they should have consultation with their physician. Thank you so much for listening to me, and I'm glad I got a chance to speak with you all. Hello everyone. I'm so glad I got the opportunity to speak to you all. Hope you will find this presentation informational and helpful. Thank you so much. Have a good time listening.
Thank you, madam. You have enlightened us how one's mental health, emotional, psychological, and social well-being and cognitive functions are associated with regular physical activities. It is very clear that physical inactivity is a major contributor to mortality. The WHO reported that around 3.2 million deaths each year are attributable to physical inactivity. Governments around the world are recognizing the importance and the large impact of physical inactivity on health and health-related expenditure. This has led to the production of global and national guidelines for physical activity. Many non-communicable chronic health conditions prevalent in both developed and developing countries are associated with physical inactivity. With increasing age, there is an increased risk of developing non-communicable chronic health conditions. In a recently published review, emphasized the direct link between physical inactivity, low cardiovascular fitness, and the presence of chronic health conditions. Then why feel old when it is almost as easy to feel young and a lot more rewarding? And why wait until tomorrow or next week when it is as simple as getting up from your chair right now and starting a fitness campaign by walking or jogging briskly around your home or institution or on the playfield? Thank you all the best. I request all the participants to fill the feedback form. That link is placed in the chat box. Now I request Dr. Haridas Kolur, Assistant Director of Physical Education, Joint Organizing Secretary, All India Inter-University Gold Medalist in Powerlifting, to propose vote of thanks. Over to Dr. Haridas Kolur.
Good evening, ladies and gentlemen. We are happy to say that the international webinar on physical activity for elderly people and other chronic diseases has concluded with a grand success. It is my pleasant duty to thank all those who have supported us to conduct this webinar successfully. First of all, I thank the chief patron of this webinar, Honorable Vice Chancellor of Mangalore University, Professor P. Subramanya Yadapadataya, for his valuable guidance and wholehearted support to organize this international webinar. Our special thanks to today's resource person, Dr. Phil Kilmer, the instructor, Department of Physical Therapy, University of St. Mary, USA, and Dr. Sonia Raval, Assistant Professor, Department of Physical Therapy, University of St. Mary, USA, for educating us with the new knowledge. On behalf of Mangalore University and the Department of Physical Education, I extend heartfelt thanks to Dr. Phil Kilmer and Dr. Sonia Raval. We extend our heartfelt thanks to Mr. Raju Mogavira, KAS, Registrar of Mangalore University, Syndicate members of Mangalore University, Registrar Evaluation, Professor P.L. Dharma, and Finance Officer, Professor Narayan, for their valuable support and guidance. Heartfelt thanks to Commissioner of Kendriya Vidyalaya Sangathan, Bangalore, Mr. Ratish and Miss Bindu, sports officers of Kendriya Vidyalaya Sangathan, and Mr. Pratap, research scholar, for their wholehearted support for the success of this webinar. I extend sincere thanks to my colleagues in the department, Mr. Shaban, technical person, Mr. Ramesh H.N., Joint Organizing Secretary of this webinar, for their wholehearted support for the success of this webinar. Dr. Kishore Kumar C.K., Director of Physical Education and the Organizing Secretary of this webinar. Under his direction, the international webinar has been organized with a grand success. Thank you very much, sir. Definitely, we remember the work done by the different persons in a large way, been responsible for this success of this webinar. I extend heartfelt thanks to all of them. I extend my special thanks to all the participants of this webinar and who have supported directly, indirectly to conduct this webinar with a grand success. Thank you one and all. Over to Director of Physical Education.
Thank you, Dr. Haridas Kulur. I also personally thank Professor Anand Shetty, Head Department of Physical Therapy, USA, and Professor Bindu, Head Department of Biotechnology, Ramaya Institute, Bangalore, and Mr. Pratap, Physical Education Director, and Miss Rupati, Physical Education Director of Besant College, Bangalore, for their wholehearted support for the smooth conduct of this international webinar. Once again, I take each and international